Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. May is Bladder Cancer Awareness Month, and today we are speaking with medical oncologist Jean Hoffman-Sensitz from the Johns Hopkins Greenberg Bladder Cancer Institute. Welcome, Jean.
Thank you so much for having me.
This is a topic that we wanted to make sure that women learned about, and you certainly are our expert, which is why we've asked you to participate in doing this with us today. Can we start off with some basic overview of the functions of the bladder?
Sure. So the bladder is a muscular organ shaped like a balloon, and it's a reservoir. So it holds urine after the urine is made by the kidneys, and the kidneys then deliver that urine into a reservoir, a separate reservoir called the renal pelvis. From the renal pelvis, urine drops down into long straws called ureters, which then insert into the bladder. And when it's time to urinate, this big muscular balloon, the bladder, then squeezes and releases urine.
When we're talking about bladder cancer, what exactly is that?
So bladder cancer is a cancer that arises on the interior lining of the bladder. I think of it almost like a saran wrap kind of lining of the inside of the bladder. And that cancer can form at any point along that tract that I mentioned previously. Sometimes it's just one tumor within the bladder. Sometimes it can be multifocal, which means multiple different tumors arising within the bladder. Sometimes those tumors can block those ureters and cause problems in terms of kidney function, or they can occur higher up in the ureters and in the renal pelvis. Even though we refer to that entire kind of syndrome as bladder cancer, some patients, about 8%, get tumors in the ureter and the renal pelvis.
In looking at the incidence and prevalence of bladder cancer, I know that bladder cancer is one of the most common genitourinary cancers in adults worldwide, and it is the fourth most common cancer in men. But we have an all-women's audience today, so tell us the situation for women.
Sure. Well, as women, we have a lot of men in our lives that we care about, right? Husbands, sons, partners, parents. One of the things that's always striking to me as a medical oncologist who takes care of this disease is that even though it's the fourth most common cancer in men, most patients don't know about the cancer until they're diagnosed or someone that they love is diagnosed. So I think it's important to, as we're talking about Bladder Cancer Awareness Month in May, to be aware that bladder cancer exists, and it is a very, very common cancer in men. That being said, it's a much less common cancer in women. But when women get the cancer, they tend to have a worse prognosis than men, which is also very important, even though it's much less common.
So let's talk a little bit about risk factors. I know one risk factor is history of smoking.
Absolutely. So the majority of patients that we see, not everybody, but the majority of patients that we see do have a history of smoking. And even if they were able to quit smoking, 10 or 20 years ago, it can still, unfortunately, have an effect. So that's just something to be aware of. One more reason to stop smoking, because another cancer-related syndrome. We're learning more about genetic links and family history, particularly for the upper tract cancers. There's a familial genetic disease called Lynch syndrome. We know much more about that, or we've heard more about that in terms of risk of colon cancer. However, those same patients with that genetic disease can be at risk for upper tract urothelial cancer more predominantly than patients with bladder cancer. And then we know that there's a link in terms of bladder cancer risk and exposure to industrial chemicals like dyes, as well as some industries like the trucking industry and hairdressers, other kinds of industries where people have been in those industries for a longer period of time. And of course, that's compounded if someone is an active smoker.
We're kind of redefining smoking nowadays. Would you say that it is tobacco use or even vaping now, which is something I'm worrying about, seeing young people not thinking that there's any harm to that? Is that something that we also should be paying attention to for our children?
Well, as a parent, it's something I definitely pay attention to. When it comes to the data in bladder cancer, I'm not currently aware of what we know about vaping. The data that we have on the link between smoking and bladder cancer is definitely linked to tobacco smoke. I think we all who take care of cancer for a living are concerned about vaping. As far as I know, the data is not as far advanced in vaping and linked to bladder cancer.
I believe there's 2 categories of localized bladder cancer. Can you talk about those?
Absolutely. When we talked earlier about bladder cancer being a very common disease with about 80,000 new Americans being diagnosed every year in the U.S., the majority of those new cases are non-muscle invasive disease. Sometimes urologists will refer to them as quote-unquote nuisance cancers. And those cancers can be of 2 different grades, a low-grade cancer or a high-grade cancer. But the low-grade cancers tend to be more surface cancers sitting right on the surface of the bladder without really the propensity to invade into the bladder. They more commonly can be dealt with by a transurethral bladder cancer resection, where urologists will go in and actually scrape the tumor off the inside of the bladder, much that we're used to with squamous cell or basal cell carcinomas of the skin, and sometimes use an intravesical or intra-bladder therapy called BCG. Then those patients get surveillance. For the most part, those tumors can be locally controlled with a urologist. The muscle invasive cancers, those are a different animal altogether. So those cancers tend to be of higher grade, for the most part are high-grade cancers, and they have the propensity or the ability to invade, meaning that they can grow roots or sink teeth into the muscle layers of the bladder. They can also invade the vasculature, and those tumors are at risk for metastasis and death, and so we treat them very differently.
Let's talk a little bit about symptoms. I know that usually the first symptom that a patient may notice would be blood in their urine. Can you talk about that and what some of the other symptoms are that we should be aware of?
Sure. So blood in the urine, either that maybe a primary care physician finds on an annual physical with a urinalysis or a dipstick, or gross hematuria, meaning blood that you can see in the restroom, is the most common symptom of bladder cancer. That blood in the urine can be very irritating and can then lead to those other symptoms that we hear about. Frequency, going to the bathroom a lot or needing to get up in the middle of the night quite a lot, pain with urinating, burning with urinating, urgency, which means as soon as you know you have to go, you really have to get to the bathroom, and also sometimes a feeling that you can't completely empty your bladder. That can sometimes come because that blood forms clots and actually causes some blockage, or just a sensation that there's still something left over in the bladder because of that irritation.
I guess we want to emphasize, too, that having blood in the urine isn't an automatic diagnosis of bladder cancer. Many women are accustomed to getting urinary tract infections that would also carry some of these symptoms, so we don't want anyone self-diagnosing themselves as having bladder cancer. Go to your primary care physician and get a definitive diagnosis so it can be appropriately managed for whatever that it is.
Oh, exactly right. Yes, there are so many different things in what we call the differential diagnosis of blood in the urine or hematuria, and more common things like urinary tract infections or like kidney stones do happen commonly. However, we need to keep the idea of bladder cancer on the list if those symptoms of blood in the urine don't go away after initial treatment.
How exactly is this type of cancer diagnosed?
So bladder cancer is diagnosed by a urologist, most commonly, who will go up inside the bladder, usually first with an office procedure, and then if needed with a secondary procedure in the operating room, where they can look inside the bladder with a scope. It's called a cystoscope, and take biopsies, and that's called a transurethral resection of a bladder tumor, or TURBT. Sometimes patients will go to the primary care physician with hematuria that is not going away, and maybe they'll get a CAT scan, and sometimes those patients will provide a urine sample, and we can do something called a urine cytology, where a pathologist can look at the urine under the microscope. That would still need to be followed up, however, with a urologist. And then, of course, if a tumor is found, we often will do imaging like CAT scans or ultrasounds for additional staging purposes.
I understand that bladder cancer occurs, as you mentioned, more in men than in women. What is the actual distribution? Is it like 70% men, 30% women, or what are those numbers?
Yeah, it's about that. So in the early stage of the disease, it's about 3/4 men and 1/4 women. In the later stage disease, there's a little bit more in terms of women, maybe about 30%. But yes, it is much, much more common in men.
Do we know why?
We don't exactly know why. I think for some time the feeling was that men had higher percentage of risk factors with the smoking and the, industrial exposure. But no, we don't completely know why. There may be a beneficial effect of hormones. We know that this is a disease of aging, and many more women who do get bladder cancer are postmenopausal compared to those that are premenopausal. But no, we still don't completely understand why more men get bladder cancer compared to women.
If a woman noticed that she did have blood in her urine, what should she do?
So most commonly, women will refer to their primary care physician or their gynecologist for blood in the urine. One of the things that we had talked about earlier was that the prognosis for women is worse compared to men. And one of the things that we think we understand is that workflow, or how women are diagnosed with the disease, may affect their prognosis. As women, it's not completely foreign to us to see blood in the bathroom, whereas for men, seeing blood may be the first time ever that they see it. And so sometimes as women, especially if you've had a urinary tract infection in the past, it may have been 20 years ago, you may come to the conclusion that that's what it is and maybe call the primary care physician specifically asking for antibiotics for a urinary tract infection. But one thing we definitely know is that when men and women complain of blood in the urine, that ultimately leads them to a diagnosis of bladder cancer. We know that men get to the urologist more quickly than women do, that women are given more cycles of antibiotic therapy compared to men. And this can contribute to something called stage migration, where if you ultimately are diagnosed with a tumor, and that tumor is diagnosed later because you had a different workflow to diagnosis, you can have that tumor for longer and it can grow or progress.
So we're camouflaging it.
Potentially.
So why a women's bladder cancer program?
Well, I think that is something as a medical oncologist, and I've been taking care of patients with bladder cancer for 10 years, is, hearing the narrative is different between men and women. So I take care of patients that have locally advanced muscle invasive or metastatic bladder cancer. And so what we see in the literature is what I experienced in clinic when I do an initial history and physical and I get to know my patients, that men will commonly have a story of, I see a urologist once a year, I get my PSA checked, and I had blood in the urine, and I called the urologist, and 2 days later, I had a scope, where it is very common to hear a very different narrative from women. They saw a PCP or went to urgent care, they got antibiotics, they went to a different doctor, they had a second course of antibiotics, they referred to GYN, doctor after doctor after doctor, until finally seeing a urologist for what ultimately is a urologic condition, blood in the urine.
Yeah.
And so when I heard about the Johns Hopkins Greenberg Bladder Cancer Center, and then learned that the Greenberg Bladder Cancer Center wanted to have a focus in really better understanding why women had a worse prognosis and then doing something about it, I was really excited to come on board.
Oh, I bet so. That's really wonderful. And it's a multidisciplinary team that's involved with the patient. Can you talk a little bit about who all of those members are?
Sure. So bladder cancer really does lend itself to multidisciplinary care. And patients, men and women, who are newly referred to the Greenberg Bladder Cancer Center really are cared for in the same way. So if a patient comes from outside of Johns Hopkins and had their diagnosis elsewhere, one of the things that we always do is we want to get that initial pathologic tissue. So we ask for those slides to be delivered so that our specialized pathologists who focus on tumors of the bladder and the genitourinary organs will take a look at those. We not only want to confirm that we're dealing with urothelial bladder cancer because there are different kinds of bladder cancer, but we also want to confirm the stage, and we do that based on how deeply we see the tumor invading into the muscle layer of the bladder. We want to get those CAT scans and those ultrasounds or MRIs that are done so that our radiologists can also look at those studies. That helps us determine the stage. And then patients are seen by one of our specialized urologists. So the urologists who treat patients at the Greenberg Bladder Cancer Center, they only are focused on treating bladder cancer and cancer of the genitourinary organs, those specialized surgeries. Not all urologists are comfortable with either bladder cancer or treating bladder cancer in women because some of the surgical issues are different, compared to men and women. And then we have 2 dedicated genitourinary medical oncologists as well as a large research staff, all interested in understanding this disease and coming up with new treatments for it.
I think that it's impossible to overemphasize the importance of having a team that specializes in this. Now, the one individual that commonly the patient doesn't get to meet or form a relationship with is oftentimes the pathologist, and yet the pathologist holds a lot of her cards. Mm-hmm. Their accuracy determines what treatment recommendations are going to be. So at a minimum, I think that women should be getting their pathology slides wherever they're getting their treatment reread by individuals, as you mentioned, who specialize in bladder cancer.
Yeah, absolutely. And I think that's one of the things that maybe patients don't realize is a service that they can ask for. We all have very busy lives. We may have children to take care of or elderly parents to take care of. You may be thousands of miles away from Johns Hopkins, and you can't imagine coming for another opinion. But what you can do is request that your slides be sent for a second opinion. We have a very, very busy second opinion service here at Johns Hopkins, and that is something that all patients can ask their doctor to do. We also have to include radiation oncologists as one of the specialized physicians that patients can see as a part of our multidisciplinary team that treats bladder cancer.
And I think it's wonderful when a patient realizes and can see that they do have a team. We're approaching this from every angle that we can and then creating the best treatment that's specifically designed for her and her situation, not just clinically, but also psychosocially as well.
You're absolutely right. And it is, I think, a little bit unfortunate that patients don't see that huge team that's sometimes behind the scenes, that a group of doctors may have sat around at a table at a tumor board where everyone is reviewing the pathology and the radiology at the same time and coming up with a consensus as to how to best approach management. So there really is that multidisciplinary team, even though someone might only be seeing one physician when they come for an opinion.
In looking at the multidisciplinary team and realizing that everyone has a special role, can you talk a little bit about standard treatments for bladder cancer?
Sure. As a medical oncologist, I have more expertise in the treatment of locally advanced muscle invasive and metastatic bladder cancer, and you could probably do a whole other hour with Armin Smith or one of our other urologic oncologists who take care of the majority of patients with bladder cancer with intravesical treatments. But for non-muscle invasive bladder cancer, the hallmarks of care are that transurethral resection, the scraping of the inside of the bladder wall, as well as installation of treatments inside the bladder. Sometimes it's BCG, which is one of the first ever immunotherapy agents. Sometimes it's chemotherapy into the bladder, but always paired with surveillance, meaning looking back inside the bladder and doing imaging. For muscle-invasive bladder cancer, the standard of care is giving systemic or intravenous chemotherapy, followed by local therapy, and that's, for the most part, surgery to remove and then reconstruct the bladder, or radiation therapy. For patients with metastatic bladder cancer or recurrent bladder cancer who have tumors that come back after that initial therapy and move into other parts of the body, then we use chemotherapy or immunotherapy.
Something that I always try to emphasize with cancer patients that I'm taking care of is the value of considering clinical trials.
Yeah, absolutely.
Can you talk a bit about that in the light of bladder cancer?
Yeah, I think one of the things that's important to understand is that everything that we know about current modern cancer therapy is based on what we learned in clinical trials. I sometimes think that when patients hear the term clinical trials, and this is a word that I use every single day for the past 20 years, this is what I do for a living, but sometimes hearing the term clinical trial, they may have different experience with it, what that term means. For me, what clinical trials are is really an expansion of the toolkit that I have to treat patients. So we always have standard of care, whatever standard of care is for your cancer. But what clinical trials allow us access to are medications that are not yet FDA approved for bladder cancer, or potentially agents that are FDA approved, but maybe they're approved for breast cancer or colon cancer or prostate cancer, but they have a biologic relevance in bladder cancer. And so what we can do is carefully discuss those options with patients, and with their permission, move forward with treatment, see how they do with treatment, and then collect information about how they do with treatment prospectively or moving forward in time, so we can inform not only their treatment, but for the treatment of other patients with the same disease. It's very important.
You're absolutely right. And those individuals who were diagnosed with bladder cancer ahead of individuals that's undergoing treatment right now have done amazing things for those newly diagnosed patients, because they have participated in clinical trials, which has established what is our current standard of care. I'm a big advocate of clinical trials. As a 27-year breast cancer survivor, I am continuing to look for clinical trials for myself that are now in the long-term survivorship space, because the more we can understand and learn, then the better off future patients are going to be. So those women who came before us really did pave the way and made it easier for us, and we can do the same for women, for which we can pave the way for them.
Absolutely.
So that is important. When we take a look at where we take care of patients, and there's a term called oncology medical homes, which in actually talking to one of my family members, he thought I was talking about a nursing home. And I thought, oh my gosh, I hope other people aren't thinking that same thing. But an oncology medical home is where you are going to be taken care of long term, not a physical place where you're going to be living. Can you talk a little bit about that and where our medical home is at Johns Hopkins for our bladder cancer patients?
Absolutely. So the Greenberg Bladder Cancer Institute is established here in the East Baltimore campus with Dr. David McConkey and his research team, the long-standing and large Brady Urologic group led by Trinity Bevilacqua, the lead bladder cancer surgeon here. But we also have the Sibley campus down in Washington, D.C., and Armene Smith, who is a woman academic medical urologist focusing on bladder cancer, runs that program there. And as you know, Sibley has been long established as a hospital and a center that focuses its care on women. And in fact, under the direction of Colette Magnet, there is a brand new focus on the multidisciplinary care of women. And so we felt that what a wonderful marriage that would be to have a women's bladder cancer home at Sibley. We welcome women here on the East Baltimore campus, and we absolutely welcome men down at Sibley. But, you know, when you think about women being diagnosed with bladder cancer and that it's a very uncommon condition for them, the experience that we hear from women who've gone through the process of being diagnosed and treated is that, you know, they enter a urologist's office, a place they've never usually ever been before, sit in a waiting room full of people that don't necessarily look like them, and then meet a physician that ultimately also does not look like them. Do you know only 10% of urologists in the United States are women?
Oh, my goodness.
Yeah. So to have a medical home focused on women with bladder cancer, we felt that it was important to have a waiting room where the other patients look like you, because we know that a lot of people do have conversations and form friendships and connections.
It's like an informal support group.
Exactly right. And speaking of support groups, that's one of the things that we wanted to have, is not only a general support group for patients and their families with bladder cancer, because bladder cancer is, even in the non-muscle invasive space, people are coming back very frequently for surveillance. There's a lot of concerns and worry about cancer coming back, and what do we do? We wanted to have at least a quarterly meeting where women could have a women's only bladder cancer support meeting, because, you know, I don't know about you, but I think most women don't want to have discussions about sexual function in front of men they've never met before.
Yes.
And that is a common worry and concern that women have with bladder cancer, especially with the surgeries that are done, the kind of reconstructions that we do. So there's some very specific things that we're going to be focusing on in this multidisciplinary space that will not only include the things that we talked about before, but also things like, you know, primary care, endocrinology, endocrinology. We're engaging the psychiatry team. In the coming weeks, we're going to be meeting with integrative medicine. So we're really excited about exploring all the resources that there are to offer with Sibley and seeing how we can really tailor them to our patients with bladder cancer.
That's wonderful. So if our listeners want to get more information, where should they go?
The Johns Hopkins Greenberg Bladder Cancer website, best way to get to that is by Googling Greenberg Bladder Cancer Center. Another great resource for patients with bladder cancer is the Bladder Cancer Advocacy Network, or bcan.org, which is a wonderful organization that we also partner with.
That's terrific. Thank you for giving us a true insight today about bladder cancer. I'm confident that our listeners are going to not just pay attention to this, but probably look in the toilet a little bit more often to make sure that hopefully they don't see anything that warrants checking further. Thank you.
Thank you for having me.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from Biosense Webster and Boston Scientific that support our podcast series, Insights That Matter. For more information about A Woman's Journey, visit our website, hopkinsmedicine.org/A Woman's Journey, and like us on Facebook and Twitter. Until next time, stay well.